Participants Lena argues the for concern side, association signals merit caution. Maya argues the against caution on causality side, evidence doesn't show causation, confounding dominates. Lena: I'll start plainly. Multiple independent cohorts show that prenatal acetaminophen correlates with more ASD-related traits or diagnoses, sometimes in dose-response fashion. When we see biochemical proxies in cord blood lining up with later outcomes, that's stronger than self-report alone. We shouldn't dismiss consistent observational signals just because they're uncomfortable. We should translate them into prudent guidance. Maya: And I'll be just as plain. Correlation is not causation, especially in perinatal epidemiology. Families differ in genetics, illness, stress, and environment. When studies use sibling control designs that hold much of that constant, the associations largely disappear. That's a loud clue that the drug isn't driving the outcome. Indications like fever or infection might. Lena: Sibling designs are helpful, but they're not magic. They can introduce other biases. For instance, if use patterns change across pregnancies, or if measurement error swells in ways that swamp true effects. Meanwhile, cord blood biomarkers capture exposure more objectively than a questionnaire. The dose-response gradients there make me reluctant to say, nothing's happening. Maya: Dose response in a biomarker study can also reflect dose response in the underlying illness-prompting treatment, or metabolic differences that travel with familial risks. If fever itself raises neurodevelopmental risk, a plausible pathway, then treating fever could be protective, not harmful. We can't just invert association signs without understanding the counterfactual. Lena: Which argues for nuance, not complacency. We can counsel pregnant patients to use acetaminophen when clearly indicated, fever, significant pain, but avoid casual or prolonged use. We can encourage documentation of dose and timing, and when possible, use non-drug measures first. That's not alarmism, it's harm reduction under uncertainty. Maya: I agree on avoiding unnecessary medication, true for any drug in pregnancy. Where I push back is messaging that implies established harm. Public guidance should not frighten patients away from controlling fever, which carries its own risks. Professional societies are clear. There's no proven causal link, and acetaminophen remains appropriate when needed. Lena: Patients deserve to know that some high-quality studies do show associations. Respecting their agency means sharing that evidence while also explaining limits. If a patient is using acetaminophen habitually for minor aches, that's a chance to reconsider. If she has influenza with high fever, it's the wrong time to debate headlines. Treat the fever. Maya: Exactly. The clinical boundary is indication and duration. The research boundary is design quality. Let's prioritize family-based designs, repeated biomarker measures, and explicit tracking of indications. Let's also standardize outcome definitions. You know how slippery ASD symptoms versus clinical diagnosis can be across cohorts. Lena: Another point. Population averages obscure vulnerable subgroups. If biologic susceptibility varies, say by sex or genetic polymorphisms, then a null average could hide meaningful risks in a subset. That's another reason I favor precautionary language about unnecessary use. It costs little to tighten casual use. The potential upside is avoiding harm in susceptible pregnancies. Maya: Precaution is fine as long as it's paired with clarity that fever control is vital and that strong studies implicate confounding. Also, equity matters. Fear-based messages can push people toward unsafe alternatives or internet myths. We must guard against replacing one risk with another because of poor communication. Lena: So our shared clinical script is use when needed, lowest effective dose, shortest duration, document use, prefer non-pharmacologic options first when appropriate, escalate to medical care for fever. On the research side, fund designs that can actually separate drug effect from illness effect. Maya. Add. Be transparent about uncertainty and avoid categorical claims. Distinguish between signals worth studying and established causation. Encourage pre-registered analyses and replication across diverse populations, not just one registry or region. Lena. What about policy labels? I'm comfortable with language noting the observational signals and advising judicious use. That empowers conversations without banning access. Maya. I'm comfortable with language that emphasizes judicious use for all medications in pregnancy and notes the inconsistency of the evidence for autism specifically. The label should not imply a causal hazard that would deter necessary treatment. Lena. In the end, our positions converge. Neither scare nor shrug. We can protect patients by balancing clear communication, practical guidance, and humility about what we know. Maya. And we can improve the evidence by designing studies that take confounding as seriously as headlines take correlations. If future research uncovers a causal pathway, we'll adjust. Until then, let care be thoughtful and precise. Lena. Then let's outline what thoughtful and precise looks like for a patient today. She calls with a mild headache at 20 weeks. I'd say hydrate, rest, cold compress. If pain persists or worsens, use acetaminophen at the lowest effective dose and check in if you need it repeatedly. Track doses in a simple log. Maya. And if she calls with a 102-degree Fahrenheit fever and chills, take acetaminophen now, seek evaluation to treat the underlying cause, and monitor response. That's where the risk-benefit calculus is clear and immediate. Lena. For researchers, publish exposure timing windows, indications, repeated measures, and negative controls, e.g., partner illness. For clinicians, keep the conversation steady and specific, not driven by social media cycles. Maya. If we hold that line, we protect both maternal-fetal health and public trust. That, more than any single study, is the foundation for good outcomes. Lena. Agreed. Evidence evolves. Care remains careful.